Good morning to everyone. I am Dr. Ranjana Atal, Assistant Professor in Gynae Department at Mahatma Gandhi Hospital. Today's topic in hypertensive disorder in pregnancy. Hypertensive disorder is the most common disorder during pregnancy. It is affected to approx 5 to 8% of all pregnant women during the pregnancy. It is the most leading cause of the maternal morbidity and mortality due to the cardiovascular accidents, renal failure and HELLP syndrome and heart attacks. It is also affected to fetus and neonates. It is causing the placental due to affected the baby due to decrease the blood flow and placental oxygenation, IUGR, preterm birth, abruptio placenta and stillbirth and the neonatal death. It's causing the fetal morbidity or mortality. Hypertensive disorder defined as the when sustained blood pressure higher more than the 140 to 90 mmHg in 2 readings during the antenatal period. It is classified in essential hypertension, listed as categories. First category is essential hypertension. It is causing the idiopathic unknown etiology. Second is chronic hypertension. Hypertension noticed either in the first trimester or patient is on antihypertensive drugs before the pregnancy. It doesn't resolve 12 weeks after postpartum period. It is due to various medical disorders as listed vascular disease, endocrine disorders, renal disease and connective tissue disorders. Third is gestational hypertension. It occurs after 20 weeks of pregnancy. It resolves within 6 weeks of pregnancy, 6 weeks of postpartum period, and it occurs without proteinuria. And in this condition, blood pressure is sustained more than 140 to 90 mmHg. And preeclampsia, it is condition defined as a gestational hypertension superimposed with proteinuria. It is unique form of hypertension, occurs only in pregnancy, develop after 20 weeks of pregnancy, and it is resolved by the 12 week of postpartum period. It is characterized by triad in this hypertension, which is mild when more than BP more than 140 to 90 mmHg on the 2 occasions apart, 4 hours apart, and severe when BP more than 160 to 110 mmHg. And second is proteinuria, which is defined as urinary protein in 24-hour collection more than 300 mg in mild, and in higher severe condition more than 500 mg. Third is edema. It is not essential for the preeclampsia. Fifth entity is eclampsia. Eclampsia defined as the preeclamptic symptoms plus seizures. So as defined as it is new onset of generalized clonic seizures in a woman with preeclampsia that cannot be associated with any other risk factors. And last is superimposed preeclampsia and eclampsia. It is occurring in women with pre-existing hypertension with chronic and essential hypertension. And now etiopathogenesis. In etiological changes in endothelial dysfunctions and placental abnormalities due to defective trophoblastic invasion. And so defined as in normal pregnancy under the influence of the progesterone, maternal sensitivity to endogenous vasopressin decreases and decreased peripheral vascular resistance. It leads to fall in the BP and increase in the intravascular volume. But in women of preeclampsia or eclampsia patient, this normal phenomena doesn't exhibit, so don't decrease in the BP and intravascular resistance increases, so blood flow decrease the baby, or it leads to the endothelial damage. Basic mechanism of during hypertensive disorder pregnancy is endothelial damage, which occurs due to the exposure of some endothelial collagen, which stimulates the release of the thromboxane A2, which is the potent vasoconstrictor which contract the vessels, and it is stimulate the platelet, which stimulate the aggregation of the platelets, which leads to the decreased blood flow. And it also decreases the release of prostacyclin PGI2, which is a potent vasodilator and inhibitors of the platelet aggregation. So it is changes in the reversal of the prostacyclin to thromboxane ratio, and so overall it increases the vasoconstriction of vessels and decrease the blood flow. This is the endothelial vessels damage leads to the soluble fibrin monomers which affected by the tyrosine kinase, which all present in the placenta and serum of patients, and it is adherent to the placental growth factors and vascular endothelial growth factors. All this leads to preventing their interaction with endothelial receptors. All this leads to increase in the endothelial dysfunction, which is responsible for the hypertensive during pregnancy. Endothelial damages It is also due to the endothelial dysfunction, decrease the placental oxygenation, because during the pregnancy, normal pregnancy, trophoblastic invasion occurs in the vessels, which occurs in the two stages. First stage occurs before the 12 weeks of pregnancy, and second stage occurs after 12 to 16 weeks of pregnancy. During the before 12 weeks of pregnancy, trophoblastic invasion occurs in the spiral arteries up to the decidual vessels, and during the 12 to 16 weeks of pregnancy, trophoblastic cells invasion in the spiral artery up to the myometrial tissue. So this trophoblastic invasion of the cells, it is destroy the normal vascular endothelium of the spiral arteries, which leads to the low resistance vessels, which increase the blood flow to the fetus. So all these mechanisms are defect in the hypertensive disorder of pregnancy, which leads decrease the blood flow, which leads to placental decreased oxygenation and tissue placental hypoxemia. It increase the release of the factors in maternal circulation, which is capable of damaging and altering the function of the endothelium. In support of this theory, trophoblasts were cultured and exposed to the hypoxic environment and released the potential vasoactive factors, thromboxane A2, interleukin 1 and tumor necrosis factors. All this leads to damage of the endothelial cells. Serum from the preeclamptic women was applied to the endothelial cell culture. So release of the procoagulants and the vasoactive factors, and serum from same woman 6 weeks after delivery doesn't exhibit this effect. So all these effects are dissolved after 6 weeks of delivery. Due to the decreased placental oxygenation leads to vasculopathy, which occurs responsible for the fibrinoid or lipid deposition in the spiral arteries. So vascular lumens are obliterated and the decreased blood flow to the placenta and baby. And second is the abnormal placental mass like multiple gestation and H-mole, and abnormal endovascular trophoblastic invasion occurs in the placenta. And the third factor is the immunological factors. Immunological factors are the most important factors in hypertension disorders. There is a decrease in normal condition. There is a maternal antibodies formed against the paternal antigen, and in hypertension disorders, decrease the autoantibodies against the placental paternal antigen. So increase the chances of the defect, and there is it is a necessity to shield them from recognition by the decidual natural killer cells and protecting trophoblasts from the rejecting. That's why preeclampsia is more common in primary, because they lack prior sensitization to the serum antigens, and it is also occurs in genetic factors. There is a hereditary predisposition of the preeclampsia, likely is the result of interaction of gene coding for angiotensinogen, methyl tetrahydrofolate reductase, and it is also occur in 20 to 40% also occurs in previous mother of pregnant patient's mother, and chances of 11 to 37% occur in sisters of preeclamptic patients, and chances of 15 to 47% occurs in the previous history of preeclampsia. Now on the pathophysiology of the hypertensive disorder in pregnancy, there is a elevated intravascular pressure and damage of endothelium leads to movement of fluid from intravascular to extravascular space, and this leads to edema of brain, retina, lungs, liver and subcutaneous tissue. And in kidney, glomerular endothelial damage, 5-fold increase in the glomerular endothelial changes during the pregnancy in hypertensive disorders, which leads to proteinuria and decreased colloidal oncotic pressure. There is a consumption of platelets and activation of the clotting cascade at the site of endothelial damage leads to the thrombocytopenia and the formation of soluble fibrin monomers, and this leads to microangiopathic hemolysis and increases it defined as the increase in serum lactate dehydrogen level more than 600 international units. And in the brain, it is causing due to placental ischemia, there is a decreased blood flow and hypoxemia. There is in brain causing the vasoconstriction, endothelial damage, and leads to all endothelial edema. And due to edema, there is a hyperreflexia and responsible for the convulsions. And in liver, the edema and ischemia leads to the hepatocellular injury with increase in serum lactate dehydrogen, serum transaminase, and stretching the capsule of the liver, which leads to epigastric pain and vomiting. Next we will discuss in next class. Thank you.